Thanks for joining us this afternoon to talk about Medicaid. It's a subject that we feel here on the panel needs more attention than it usually gets in the press. And I'm going to tell you why briefly and give a little bit of context for our discussion here today about Medicaid and the future of healthcare in Texas here. This year and next year, over the next biennium, 2016-17, Texas will spend more than $62 billion on our Medicaid program. That's not for Health and Human Services, that's just for the Medicaid program. That program now consumes nearly 30% of our all-funds state budget, state and federal dollars combined. For years, however, that amount, the Medicaid share of our general revenue budget, state funds, has been increasing as a share of the total budget. And that's an important thing to realize, that the amount of state dollars we put into the Medicaid program as a share of the total budget has been growing, and it has been for years. Last year, during our legislative session, a relatively small supplemental appropriation for Medicaid marked a historic milestone. For the first time in Texas history, the state was spending more on health and human services than it was spending on education, K through 12 and higher education. That is to say, Article 2, which is health and human services, exceeded Article 3, which is education. That had never happened before, and it passed without much notice in the media, but it did not pass unnoticed by legislative appropriators. Because so much of the Medicaid budget is funded by federal dollars, even small changes to the federal reimbursement rate can result in a transfer of hundreds of millions of dollars from federal coffers to state taxpayers. And this is what happened last year when a very small percent decrease in the federal Medicaid match rate meant that state appropriators had to find about $600 million in state funds to fill that gap. This is something that state lawmakers and state appropriators have no control over, the federal match rate. It's called the FMAP. Small changes can mean big things for state appropriators. Given the context of what is happening, what we see happening measurably to the Medicaid budget over time, if we do nothing, but continue as we are, eventually Medicaid will begin to swamp the state budget. It will require cuts to education or other budget priorities or tax increases or both of those things. We don't want to have a discussion today about the Medicaid expansion of the Affordable Care Act. We've talked a lot about that, and we've heard a lot about that over the past couple of years. We want to talk instead about what Texas can do to stabilize the Medicaid program we have today, to make it sustainable in the long term, and to make sure that it is the kind of program that the people who are enrolled in it now and who rely on it can have confidence that it will continue to provide the care that they're going to need going forward, and that it can be the kind of program that we need it to be as a state as we grow for generations to come. I want to introduce my panelists one at a time to come up here and address the question before us, a very broad question. They're going to tackle it from different angles, and then we're going to have a period of question and answer and discussion up here about what they discuss. To my immediate left is Camille Miller. She's the president and CEO of the Texas Health Institute, an independent statewide 501c3 nonprofit. She's been in that role since 1996. As Chief of Staff for Texas Senate Committee on Health and Human Services, she supervised legislative interim studies on medically fragile children, reorganization, and conducted one of the most recent comprehensive studies of Medicaid in Texas. In 1995, the Texas Hospital Association selected her to be director of their Medicaid project and immediately promoted her to director of regulatory affairs, asking her to be the first president and Chief Executive Officer of the Texas Institute for Health Policy Research. In 2009, she received the Lifetime Achievement Award from the National Association of Social Workers from both the Texas chapter and the Austin chapter, And more recently, she was appointed to Advisory Council at the University of North Health Texas Science Center School of Public Health just last year. Please join me in welcoming Camille Miller today.
Well, thank you very much, and I'm so glad you all are here. When I woke up this morning, I had on my mind, how do you kick off a discussion like this? And what came to mind is what I say to all the interns that I get to supervise and to some of my preceptees, and that is, this is the most exciting time in your life, in my life, and in the future of all of our lives to have a major impact, good or bad, on healthcare in Texas. And if we can make a difference in Texas, we can make a difference in the nation. And my job on this panel, first of all, is to give you a quick overview from a federal kind of a perspective. So these slides are going to be available, or maybe already are available, posted online. I'm not sure, John.
They will be.
They will be. So don't try to write things down or whatever. You will have these slides available to you, and they are all sourced, and they're all public sources, and we have permission to use all of this information. So I encourage any of you that find any of these slides helpful, please feel free to use them. So the topic is financial realities and the future of U.S. healthcare. Let me figure out how to get this going here. First of all, by far, the most expensive healthcare system on earth is the United States healthcare system. And this graph, better than anything else I've seen, really depicts the stark position that the United States is in. U.S. healthcare ranks last among these wealthy countries, or the wealthiest countries in the world, when it relates to our overall healthcare outcomes and rankings. And that's healthcare quality, access, efficiency, equity, and things like infant mortality. So we've got a system, but it needs a lot of improvement. Aging boomers and Medicaid enrollment increases produce concern about the sustainability of current favorable federal spending levels. Sustainability is one of the major concerns that anyone who's involved in healthcare has to begin to grasp and to begin to become a part of the solution. So I cannot stress on any of you too much the fact that we are in a totally unsustainable system. We cannot continue to do what we're doing. We have got to change. And who makes those changes is really important. And I would encourage all of you, all of us, need to be a part of positive change. CBO and CMS, Congressional Budget Office, and Center for Medicaid and Medicare Services projects the return of healthcare cost growth to near historical levels. And the data more recently on this is that it is definitely meeting up to those expectations. The increases are really huge. And so what is the future? U.S. healthcare's long-term futures choices are really fairly limited at a 10,000-foot big picture level. We can increase out-of-pocket cost dramatically so that each of us have red meat, not just skin, in the game. Or price controls become common. All payer rate setting, global budgets, and outright caps. And some of that is beginning to happen. Or we bend the curve. And, there are some things in place that are beginning to look at how we can bend the curve. But a lot of bending that curve has to start at the local community level, and it has to be implemented at the state level. All healthcare is local. All healthcare is local, and you can pass all the laws you want at the federal, state level, but unless it is implemented at the local level in a different way than we're doing things now, we are going over the cliff. And what does bend the curve mean? Improve coordination, measurement, and evaluation of care plus reimbursement reform. So the U.S. is currently pursuing two of these three simultaneously. A friend of mine did this slide, and I stole it from him. He calls the two major areas that are being implemented now Berwickian nirvana of large accountable care organizations, which encourage rationalization of the delivery system, and the atomistic view of consumers armed only with high deductibles. That's the definition of consumer-directed right now, where health plans will impose market discipline on providers. If you begin to look at the impact of what's being tried right now on the population in need, U.S. median household income is $51,000 annually. That's far below the mean of $71,000. So that's that's a pretty big difference. The fundamental challenge is while incomes and asset bases vary considerably, the prices for healthcare goods and services generally don't. Goods and services just generally don't. Although some employees are varying their premium contributions based on pay. And that means that when you pay a $1,000 deductible, it's a rounding error for the top 1%er, but it has a far more serious consequence for a median income household. And I'll show you another slide in a minute that makes that more starkly a contrast. Consumer engagement strategies that involve significant cost shifting are therefore highly regressive. And if you look at the national poverty rate and you remove and you add the 3.3 million when household incomes are adjusted to reflect the out-of-pocket medical spending, you would increase our national poverty rate by 10%. I mean, our medical expenses are just eating into our incomes, no matter what salary level, income level you are. But if you look at the lower income people, it is really making a difference. And so you can see that $1,000 deductible we talked about a while ago is like for the top folks, 4.5% impact on their income, but on the majority of the population, it's a 60% impact. So this makes it also a system that's just not sustainable. We can't keep passing the cost along. We can't keep sustaining this level of cost. And so some people say, well, let's have people use their savings. How many of you know someone who's already exhausted their savings based on a medical condition? Anybody? Yeah. And many who proud poor Texans are not admitting it, but they're on the brink. And so this is a table that shows that basically we are not big savers in America. We don't have savings set aside. This to me was I saw this for the first time about 3 years ago. This is shocking to me that there's not more money available in savings. And so people are really at risk. And then some initial savings, but are also trade-offs. Families switching to consumer-directed plans spent 21% less on health care the first year. There's no assurance that'll continue, but if you look at how, and this study looked at how that was accomplished, 2/3 of the savings came from lower usage, 1/3 from paying less per episode. So it's a trade down to, and also a trade down to generics versus branded prescriptions. Enrollees cut back on use of beneficial services like preventative care and primary care physician visits, even though such benefits were fully covered by their services, by their benefit plans. This is alarming. There's a growing support for price controls. And one of my board members on the Texas Health Institute board follows this every year. And this is done about every couple of years, and it is very, very disturbing. Price controls come with their own problems. Demand for health care always outstrips supply. Temptation is to cut back on reimbursement per unit of care in order to make numbers work, resulting in hamster care. Leads to unsustainable hollowing out of our health care system over time, and price controls are at best a temporary rather than a permanent solution to excess health care spending. Healthcare systems in our country and in our state are beginning to recognize the need to be profitable at Medicare rates. Many require cost reductions of 21%. And so you can see that 71% of healthcare systems in the U.S. agree that they will have to learn how to make money on Medicare level reimbursements. We are in a business model change that is incredible. We are moving from vendor to orchestrator to owner of the population. And I've just been given a 5-minute here, so I'm going to rush a little bit faster. At your leisure, take a look at this slide. The world is being turned upside down, and we are in that gap between this world right now, which means that it is going to get a lot worse before it gets better. The number of accountable care organizations has grown rapidly, but it's beginning to plateau. What are these accountable care organizations doing? They're building networks of facilities and providers. They're signing risk-based contracts. They're gathering, aggregating, and analyzing data more than they ever have before. They're identifying train wreck, high-user, high-cost patients who represent the largest financial risk, and they're not just creaming them anymore. They're really trying to make a difference in their health. They're discerning gaps in care, and they're intervening with case management tools. And what are they finding? Medical care is only a small contributor to population health. We are now trying to learn and embrace social determinants of health. There's a lot of work that's been done on this, but there's a very high correlation between your status, your societal status, and your health. And tobacco use, diet, exercise is also correlated with economic status. And pay status is a more important predictor of cardiovascular disease than the classic risk factors. And so what are we saying? Less education, worse health. Lower income, worse health. And lower income, more chronic disease. Traditional health insurers are also focusing more on social issues. WellPoint and CareMore are two. Supporting networking with friends and family, looking at living situations, preventing hazards, looking at diet, access to healthy food, transportation to medical care to and from, and ability to afford prescriptions, and health literacy and mental acuity. And particularly the health literacy is just so important. And what is health literacy? It's being able to navigate the healthcare system in your own individual best interest. How's this affecting ACO behavior? They're finding that maybe social workers and other kinds of navigator type folks are more important than care managers for high-risk patients. There's a realization that we need to move the mean for larger swaths of the population to be under management, and over time expected heightened focus on classic public health issues and health equity as a major determinant of health. There's a growing need to develop, purchase, or partner to acquire skills. So putting it all together, U.S. healthcare economic strains mean that this historical system is unsustainable. If you take nothing else away from this presentation, the current system is unsustainable. It has to change. Consumer cost shifting and price controls both have inherent problems that make them unsustainable as core methods of addressing the problem. Focusing on value and shifting responsibility to supply side right now seems to be working best and offers the greatest hope for sustainable solutions. At-risk providers will increasingly need to reach beyond the classic tools of healthcare delivery to management and improvement of population health, and newer focus on issues of inequality and social determinants of health are highly likely, and your knowledge and skills in these areas will become increasingly important. So in closing, the pessimist complains about the wind, the optimist expects it to change, the realist adjusts the sails. Thank you.
Thank you, Camille. Next up, we have Dr. Vance Ginn in the center of the panel there. He's the chief economist at the Center for Fiscal Policy here at the Texas Public Policy Foundation, was a professor at Texas Tech University and Sam Houston University from 2007 to 2013. He has published articles in academic journals such as the International Journal of Finance and Economics and the Journal of Business Strategies. He earned his BA in economics and accounting with minors in political science and mathematics before earning his PhD from Texas Tech University in 2013. And he is the co-author with me of the paper that should have been on your seat when you came in, which he is going to discuss with us today. Please join me in welcoming Dr. Vance Ginn.
Thank you, John. Good afternoon. Hopefully you're all doing well today. It was tough to follow up after the lunch presentation, but hopefully we'll be able to meet some remarks here that will carry weight. It was a great presentation. So you have the paper there, so I'd like to go over a few things and reiterate some of the things that John discussed earlier. So here's my presentation, Reforming Medicaid in Texas. As many of you know, there's been skyrocketing Medicaid cost here in Texas and across the nation. Even from those, I know we're not getting into the expansion part, but even those states that have expanded, when you look at Ohio's costs and Indiana, they are far above what their initial projections were going to be. So there's a need for reform that I think Camille hit on quite well, of the unsustainable costs over time. And what they're continuing to do is to crowd out other budget priorities that you have that legislative appropriators seem to have. You have transportation, you have education and other areas, and that's crowding out other budget priorities by the skyrocketing cost that we have in the healthcare system, in particular with Medicaid. When you look at the overall Texas state budget, 2016-17 budget was $209.4 billion. So on one side you see the revenue, the amount of money that's coming in, about $106.6 billion of that, about half, is your general revenue, with about half of that coming in from sales tax revenue. And then where are those dollars going? Well, about three-fourths, so 75%, go to health and human services and education in this budget, with the vast majority looking at, those two. But you have $77.2 billion in health and human services, so it's a large portion of the budget. As John mentioned, in the 2014 legislative, or over that budget period, when you include the supplemental that was passed during the most recent legislative session for Article 2, there in the red, point over there, you have $74.5 billion. That exceeded Article 3, $73.9 billion in education, and for the first time. And this is a trend that maybe might slow down a little bit when you look at the 16-17, but with the continuing skyrocketing cost of health care, Article 2 will eventually surpass education if something is not changed. In other words, it's on a sustainable trajectory. When you look at Medicaid, Medicaid is 80%, $61.2 billion of overall Article 2. And so this is a major issue that we need to think about. And as John also mentioned, this is taking over a larger share of the overall budget. It's up to 23% of overall general revenue, and since 2002-03, that's an increase of 42% of the overall share of the budget. It's a huge amount, right? So I think that shows there. So what we've looked at, so it's kind of the past history. I think John already did a good job of mentioning those things. So how do we look into the future? And I think Camille opened it up nicely into my presentation, looking at it's on a unsustainable trajectory. So what are we going to do moving forward to allow for Texas and other states to have some sort of way, some sort of an example to move forward to put on a sustainable trajectory so that taxpayers aren't footing a larger bill, right? Because spending is taxation. So if spending continues to rise at a rapid pace, we're going to have to pay higher taxes. So how can we overcome that so we can sustain what we've seen in the Texas model of job growth and everything else over the last 15 plus years? Well, what we call it this Texas Medicaid reform model, this market-driven, patient-centered approach, where one example would be to use a federal block grant, right? So we have a federal block grant that would be sent to the states instead of the matching funds that we have today under the FMAP, Federal Matching Assistance Program. And this would allow for states to have the flexibility to come up with their own ideas, own ways of having more independence to basically provide the best health care for the patients for that particular state. So in Texas, Texans are going to understand the needs of Texans and those patients more so than I believe than those in D.C. And so when you look at this, we looked at five specific groups. Well, it shows 3 here, but 5 overall, where you have pregnant women, children, which are broken down at different age groups, and TANF-eligible adults. Those are the major 3 groups that I think would be most likely to go underneath our overall plan that we've looked at here. And so this would take federal and state Medicaid funds to subsidize private health coverage instead of the system we have today where they're just on Medicaid. They may not have access to quality care. Many of those that are on Medicaid today are being turned away, so they're not getting good quality care. And the outcomes that they're receiving from being on Medicaid are much lower than those that are on private health insurance. So this is a way to improve the overall betterment of those individuals, the well-being of those individuals who are currently on Medicaid, and save taxpayers some money in the process. All right. So what we did was with this overall model is we took, what was it, a year or two? I mean, it was a while. I think it was about 2 years where we met with Health and Human Services Commission and looked at a lot of the data that they've put together and looked over the forecast of the next decade. So it was fiscal year 2013 through fiscal year 2023, per member costs for these different risk groups. And we looked at all this data, and then we said, okay, well, what are the average monthly subsidy costs per group that we would provide to provide for private health coverage? And so what we did was we first looked at it and said, okay, well, what coverage are they going, what coverage could we use, right? What would be a good example? And so what we looked at was the federal exchange. And we looked at the silver and the gold plans that are out there today among the top 10 most populated Texas counties. I mean, that's a large portion. 60% of the state's population is in those top 10 counties. So let's use those. Let's find the average subsidy cost and move forward. So how do we determine what these subsidies were going to be in this defined contribution sort of a plan? Well, it's a sliding scale subsidy scheme. So you start off at 100% FPL, which is about $11,000 a year when you use 2013 FPL, which is our first fiscal year that started this overall modeling. And basically they would get from 0 to 50% of FPL, they would get 100% of their premium paid, whatever that amount was, whether it's under the gold plan or the silver plan, which I'll talk about on the next slide. Up to 175 to 200% FPL, 65% of their subsidy of their premium would still be subsidized by the state under this federal grant using state and federal funds to pay for this overall amount. Where the maximum FPLs would be 185% for newborns and pregnant women, which is the current system today, 100% for children ages 6 to 18 and TANF-eligible adults, and 133% for children ages 1 to 5. So using this sliding scale scheme, we can then start to think about how much the cost would be for individuals in these particular risk groups: pregnant women, children, TANF-eligible adults. So for an example, I think it kind of brings this all together. So let's say there's a pregnant woman. She's enrolled in Medicaid, right, with income of $920 a month, less than the 100% FPL. So the cost of her care is likely to be higher than others. She goes to the doctor more often. I have a 16-month-old son, Bryson, so I understand my wife went to the doctor pretty often. I tried to go with her as often as I could. But those costs continue to rise pretty quickly. So if she's offered a gold plan that's able to cover more of these costs on the federal exchange, using these averages, it's about a $435 premium without any subsidies or anything else. So given her income level, that FPL level, it would provide state would provide a 90% subsidy of $391 a month compared with a current cost of $718 per month. So that $718, that's provided by Health and Human Services. That's what the average per member cost is to provide care in the Medicaid system for a pregnant woman. So the cost savings, just by providing the subsidy for private health insurance, would be $327 a month, right? Given her monthly contribution for private health coverage, where she can now go see any doctor she wants, not just one that's going to approve of or accept Medicaid services. Her monthly contribution would be $44 or 4.8% of monthly income, which is less than under the Affordable Care Act maximum of 8%, right? So there's still some skin in the game, which I believe Camille called that red meat. This isn't necessarily red meat, this is still a small portion, but at least there's some skin in the game that allows for behavioral changes and allows for them to get better care. I mean, that's the key part. So when you compare these among these different risk groups, right, we have the current status quo of what the costs are for these risk groups per month for Medicaid, and here are the averages over these top 10 counties of what the subsidy amounts would be. So for each month, these would be the savings for each one of these risk groups. So for newborns, it's about $662. For a gold plan, it would be $169, right? And so you kind of go through this. And so we had a huge model that I helped put together to try to figure out what exactly these cost savings would be over time when we looked at acute care services and also long-term care services. And we assume the same trends that HHSC does given the current system. So without any behavioral changes or anything else, we consider these to be pretty conservative forecasts moving forward. And here are the key results. So substantial cost savings under the Texas Medicaid reform model. All right? The blue here are the data that we received from HHSC from fiscal year 2013 on the amount for Medicaid, $22.4 billion up to $42.4 billion, given the amounts that they included in these in their data. And then based on our risk groups, right, and subsidizing for a certain percentage of their premium, this is the amount that we show. So let's say in fiscal year 2015, the savings would be about $4 billion just in that 1 year. And then it continues each year until you get out to, well, just as far as we went anyway, to 2023 of savings of $6.1 billion. So that's per year. So over the fiscal years 16, 17, you're looking at savings of about $9 billion that we could have from an approach such as this. And like I said, I think these are more conservative than what they otherwise would be, where you start to see the red, instead of going at the same rate of growth as the blue, I think you'd actually start to see it level off over time and allowing for more patient-driven healthcare instead of more government-driven that we have today. Results are likely very conservative. Not only do you have the behavioral changes taking place, but you also have inflated insurance costs today under the federal exchange program. There's very little competition that's going on there. So if you allow for more competition among these private insurance providers, that would also allow for lower premiums and therefore lower costs that would be subsidized by the state. And in general, I mean, poor and the taxpayers deserve better. They deserve better care for those who are the neediest among us. They shouldn't be turned away. They should allow for an opportunity for them to get the best service available. And we're not providing that today. We need something to be able to put this in motion moving forward. And taxpayers should get the best bang for their buck. And in some sense, they're not being able to provide that today. So overall, that's my presentation. I look forward to any questions or comments afterwards. Thank you very much.
Thank you, Vance. Next to Vance is Representative Garnet Coleman. He has served the people of District 147 in the Texas House of Representatives continuously since 1991 and is currently the senior ranking member of the Public Health Committee, as well as the chairman of the House County Affairs Committee. He currently serves as member of President Obama's state legislators for health reform and currently serves as co-chair of the Progressive States Network, an organization that promotes and advances key progressive economic and social policies. The recipient of numerous awards, including the Texas Association of Counties Champion of County Government Award, Texas Suicide Prevention Council Public Policy Leadership Award, Texas Medical Association Friend of Medicine Award, and many more. Representative Coleman attended Howard University in Washington, D.C., and in 1990, he graduated from the University of St. Thomas, cum laude with a Bachelor of Arts. Please help me welcome Representative Coleman.
Well, first of all, it's really good to be here today, and I appreciate the invitation. We often talk about differences, and I think what's important is that the group of people sitting up here believes in one thing, that people need care and they can't afford it, and that we have to do something to make sure that the individuals who need care can get it at a cost that they can afford, but also that they are a participant in their health care, both from a wellness point of view and from a financial point of view. And, we often hear that doesn't make a difference. Well, how do we know if we don't do it? And so around the country, the idea of people putting into their own premiums as well as in copays really will have and has had an impact on utilization of the system. And we have enough time to see whether or not there's any negative impact from those small percentages of the cost of people's health care based on a sliding scale. And the key ingredient there is a sliding scale, because once you get below 50% of the poverty level, it's very tough for anyone to do any contribution. But people are willing to do contribution even if it's a quarter. And I'm not joking about that. I'm saying that somebody feels good about their ability to do what they can. We have systems like that now. You see that in most of the larger hospital districts across the state, where there is a contribution for the indigent care, what we call indigent care, to receive the benefits from those particular hospital districts and indigent care counties around the state. We often hear about the care that's provided, both I know in my hometown in Harris County, there is a sliding scale, and we go up to 200% of the poverty level. But as you go up, people are requested to pay part of their care in San Antonio, Bexar County, CareLink. People actually have an amount that they pay every month in order to receive that indigent care service, and are a part of that system, whether it be a copay or what we would call premium sharing. And so generally in these situations, you see both a copay for each visit to a provider, but also just like people in their employer-employee situation, they pay a part of the premium for the health care that they receive. And looking at the sliding scale that was in the paper, that makes a lot of sense, particularly when we start looking at children and then the acute care for the disabled and the elderly, because these are individuals that are either beyond or cannot work, or whose parents don't make enough money to care for them, and they're in the totally dependent upon that parent. So with that sliding scale, I believe that we can use the systems that we've seen in our counties that deal with people who are mostly below the poverty line because they wouldn't be eligible for Medicaid because they're either single adults or they are not citizens or they don't have eligibility or they're those are the individuals that end up in our accounting system. But in our Medicaid system, we end up with disabled and basically children. The big cost in Medicaid, quite frankly, and we talk about this all the time, are the disabled and the elderly in long-term care. That's one of the largest driving costs of increased payments in Medicaid. But one thing we know is that as the number of people who come into Medicaid, and if we don't do something about the cost per unit of treatment, as well as the overall cost to our state and to our nation, as Camille said, it's just not sustainable. It's just not. And that means that it's a drag on everyone's health care, as Camille showed in the chart, because it means that those who can afford will end up subsidizing the entire system through a cost that's added to their particular, not just maybe their insurance, but more importantly, the cost of actually buying the service by the insurance company. So we've moved in a direction of bending the cost curve. I want to talk a little bit about innovation because it's important that we use these exciting times to try things we haven't tried before. I was at a deal with the Center on Medicaid and Medicare Services in it was a conference, learn thing, go learn. And so I asked the people from CMS, I said, well, has anyone ever applied for a block grant through a waiver? And the answer is no. And I believe that under the innovative systems that are being put in place in that place that people don't like to trust, Washington, but at least there are some mechanisms for innovation that's something that Texas ought to try. To look at a way to reduce cost and also have the flexibility to do things that require people to participate in their care. We've tried it the other way, and it hasn't necessarily worked. And I think it's time for us to try a way that people want to do in the state, want to try, but we haven't had that opportunity. And I think we have some systems on the local level and clearly on the state level. We have changes in how healthcare is structured through accountable care organizations, which are the bigger experiment now. But the likelihood that those actually do reduce costs is a high likelihood without sacrificing quality. Where we are right now is the choice is being diminished in the exchange for the care that you get because of the networks being very narrow. And so the choice of hospital, the choice of physician or who provides that care is shrinking. And in that, it may be that the care isn't worse, but the choice is not there. So as all this shakes out, the most important thing that we do is to make sure that whatever system we use, because we didn't have one until now, whatever system we do use moving forward, that system continues to contract costs. And how you contract costs is through wellness, so the idea that people don't get sick. And this is the future because instead of having all the costs go to treating people who are sick, population public health along with primary care is something that can save all of us money in the long run. And that is the way that we're going to get this cost curve ultimately bent, but our system isn't set up for that yet. And so as we move along, as the system is set up for wellness, I do believe that we will all see some reduction in costs. And also incentives for people to be a part of the cost of their, to share in the cost of their care at lower incomes. These are the things we must try, because I don't think I've been in a room when it doesn't matter somebody's point of view, where they believe the system as it is or as we changed it is sustainable without changes as we move forward. But those changes have to mean that people have to be responsible for their care, learn how to be responsible for care and health literacy, and make sure that they're responsible for not getting sick. And that, if you prevent chronic disease and disease that costs us, everybody, a lot of money, then by reducing that chronic disease, we will have a more sustainable system. And I can attest to that because I have type 2 diabetes and I've been hospitalized twice. Now, did I really need to go? I don't know. They said I did. But it is about controlling your blood sugar. And it's not as easy as people think it is, but to be safe, if your blood sugar is out of control, you go to the hospital. And something that you didn't have a bill of $3,000, now you have a bill of $3,000 or more, depending upon how many days you stay. So the chronic illnesses and our health conditions are really affecting the cost of our health system by having people with multiple chronic illnesses. Oh, I have those too. I have multiple. But so they end up costing all of us a lot. So by being well and preventing illness and intervening in illness and restarting that as a way that our society works in terms of what we do, then I think in the long run we'll reach where we need to be because we'll have less people that are engaging in the healthcare system for things that can be prevented and intervened in. So again, the takeaway, I think we ought to try the block grant. I think it's very important. Somebody's got to try it. Why not Texas? I think it's important that we reform the Medicaid system so that it works for patients, works for providers, but in particular works for the taxpayers. Because if the system isn't sustainable and the taxpayers don't think it is, then that will clearly be something that people won't have any trust or faith in and don't want their money to go to. So the system has to work in that regard. And the last, that when we're doing cost sharing and premium sharing, that we look at where the breaks are in that sliding scale to make sure we don't put people in a position where they can't do something, but have everyone participate in some way. And as that income goes up, that participation goes up. Now, I know there's some people in this room, and I've been doing this since, Camille was still in state government when I came in and being but in the final analysis, we care about our brothers and sisters, and we are our brothers' keepers, and we don't want to walk away from people. And the reality is, we don't have to pay as much as we're paying, and we'll do the right thing. But we always expect people to, and particularly in Texas, to carry their own weight as a part of that. So I think that Texas should turn back to that concept as a way to provide care, but at a cost that is reasonable and with participation that is dignified. So thanks for letting me come out today. Thank you.
We do have time for some question and from some discussion, and as moderator, I'm going to exert my privilege to ask the first question, and then we'll go to your all's questions as well. And I'll throw this to the panel, particularly to Camille, but anyone on the panel is free to respond. Camille, you talked about the different approaches to healthcare reform and the different parts of the healthcare system, so to speak, that we have, and that there is most promise in looking at incentives to bend the cost curve on the supply side for the providers, to incentivize providers to reduce costs. And you mentioned ACOs, and Representative Coleman mentioned ACOs as well. And I wonder, because you have been involved in the healthcare system in Texas for so long, if you could speak to past efforts, for example, in managed care. The idea in managed care was let's take incentives, shift incentives from providers to provide bulk care and through the fee-for-service program to make money by pure volume, and try to shift them into managed care, managing populations, managing groups of people. That is something that has been around for a while, that we are expanding out to different parts of the state. Most of the Texas Medicaid program is now managed care. This is also a national trend. Can you give us some context, because the idea of bending the cost curve by looking not to the consumer but to the provider is not new. And so I wonder what lessons that has for us when we start talking about ACOs and to start talking about how to bend the cost curve in that way.
John, what a great question, because when Bullock asked me to do the study, Lieutenant Governor Bullock asked me to lead the study on Medicaid at the time. He asked the question, how do we do managed care? Well, that was the wrong question. We did go about and design a way to implement managed care, but since we'd never done it before, what we ended up implementing, not the design, but what we ended up implementing was managed cost. And that is a great lesson for, as we look toward this block grant. I mean, I'm with Representative Coleman. We need to grab this opportunity with this block grant and show people what we can do if we can engage the knowledgeable people at the local level with what's already working, use their knowledge and expertise, because if you just manage cost, then all you're doing is rearranging the deck chairs on the Titanic. And that's what we did when we implemented managed care. Quote, we called it managed care. We're only now, in my opinion, in the state of Texas, beginning to really look seriously at how to do managed care in our Medicaid program. And it is never going to be done until those local providers become partners with us, hospitals and doctors and all the different healthcare providers and the public health departments and others that can help us with health literacy. Because until each individual understands how they best need to access, when to access, how to access, and what to do themselves to be as healthy as they can be and their family can be, we're never going to make a difference with this situation.
If the panel doesn't have anything else, we can go to questions in the audience. And I see the first question there on the aisle in the back. Do we have a microphone?
I'll talk loudly.
Okay.
I think the consumer can help in this, but the consumer has to have knowledge of alternatives. Every few months, the Wall Street Journal provides us data on health costs in various cities for regular procedures, and they vary 200 to 300% in cost. Now, I asked my son, who went to LBJ Public Policy School, I said, why isn't there a better dissemination of information? He's told me that the Medicare Advisory Commission keeps track of all the costs of all the hospitals and all the procedures throughout the country. If we're going to be knowledgeable consumers and capitalism is going to work, this needs to be disseminated. I was in a man's business, banking. If those of you who've been in Austin a while, they used to print the different rates for CDs, money market funds, every Saturday in the Austin Statesman. I see no reason why papers can't be encouraged by the legislature to provide information as to what normal procedures cost at various hospitals in various cities around the state of Texas. I think we can lead by making knowledgeable consumers give them the choice. Certainly there's no choice when you're in an ambulance, but there is a choice if you're seeking care for type 2 diabetes, in my case, prostate cancer. It's a lot easier if you have knowledge. Then you can shop for what's good for you.
John, could we get people to say who they are and where they're from?
Yeah. If the gentleman can say his name and where he's from quickly.
Me?
Yeah.
I'm from Austin. My name's Wayne Hartman.
Okay, great. Yeah, when we're calling you, yeah, just say your name and where you're from. So the question about prices, and Vance, perhaps you can speak to this. One of the persistent problems in the healthcare system is that you don't have prices really the way you do in other sectors of the economy. If you don't have prices, how can you have competition? How can you bring market forces to bear and actually have providers competing for patients, right? That's right. And that's part of what we talk about when we talk about skin in the game and consumer-directed health plans, and incentivizing patients, not just providers, but incentivizing patients to seek out the right care at the right time in the right place. So I don't want to answer the question for you, but what are your thoughts on healthcare prices?
Actually, but yeah, exactly. I mean, that's what economics is all about: is prices, allocating scarce resources efficiently to where they're supposed to be, best used to meet our desires. And in the healthcare system, the lack of prices blinds us from what we could have in the future, and be able to it blinds providers and patients from coming together in an optimal way, based on the contracts that are behind the scenes too. I think those really keep us from seeing what the prices are. I mean, I think if you put it in the paper how much the costs are at one location, that may not be the cost across all locations, and it depends on whether it's Medicare paid or Medicaid paid or private insurance paid, and which private insurance company is paying. You got a lot of different prices that are out there. I do think long term it would be, or even today, it'd be best to have prices that are available online, so that way you could go out and compete and see who's going to provide what at that particular time. But we have a long way to get to that point. And so I think we need some of these other approaches, like a federal block grant or something along those lines, that's going to allow for doctors to come closer together with the patient. And that's really what this is all about. And too often we're getting separated from that overall market activity.
Yeah. So we have a question up in the front. So your name and where you're from, and try to keep the question brief, because we do have limited time. We want to get to a lot of other
I don't have a question. I just want to respond to the gentleman in back. I've been in medicine for 48 years, and I've watched the tragic changes that have happened. We have gone from first place in the world in 1968 in education and medicine, healthcare in general, to 37th place in the world right now. We rank behind every industrialized country in the world. Regarding transparency of prices, in the past year there was a total knee done on a patient, $6,000 was charged. Another total knee was done by another orthopedic surgeon, $88,000 was charged. Same zip code, Blue Cross Blue Shield paid both of those without asking a question. But there are transparency books out there right now. Healthcare Blue Book, a number of other ones, Compass, provide charges, so people have those. But if somebody gets a charge on a operative procedure and they say it's $6,000, and that's low, but we got to charge a $500 copay, and then another person charges $30,000, but the copay is only $100, who do you suppose they're going to take? I mean, these things, unless you standardize them, and then when you talk about block grants, the government, pardon my shaky voice, my wife died this year from this healthcare system, and I'm not very fond of it. These things that are going on right now, you want to shift this to the government has already thrown this on the backs of all the doctors. The doctors in the United States are getting so, and a large percentage of Texas doctors do not accept Medicare and Medicaid patients anymore. And when you do not accept Medicare and Medicaid patients, I don't know where your ethics are, but these people end up in an emergency department. The average emergency department cost today is $2,000. I travel all over the world as a missionary. I get better care in Africa than I do in the United States. And I get better care in Mexico than I do in the United States. Yeah. And right now, our system here is so broken and so bent and battered that if you want good medical care, you got to go to another country.
Yeah, I hear what you're saying, sir. I do want to be clear, though, about one thing, that we are talking here about primarily about the Medicaid system, and so it is a publicly funded system. The majority of the funds come from the federal government, and with those funds come strings attached. And so some of the things that we would like to try to do if we had a block grant are to incentivize, or rather de-incentivize, people from seeking care in the emergency room, which is costly and more ineffective than this preventative care that we're trying to see, that we want to see incentivized. There's another question I have. I'm sorry, so we got to move on because we got a lot of hands up. There's a woman in the back there standing. If we could go there, and then we'll come back up forward.
Hello, thank you for taking the question. My name is Debbie Ploganoff. I'm an anesthesiologist from Tyler, Texas, specifically pediatric anesthesiologist. I've taken care of thousands of Medicaid patients in my career, lots of Medicaid kids. And this question is really for the panel as a whole, because I heard things from each of you that kind of tie into this about incentivizing and getting some buy-in from patients. I will tell you that when you talk with the Medicaid patients, a lot of them are just like any other patient that we take care of. They understand their health care. They understand their system very well. The one thing that I haven't heard anyone touch on, though, when we're talking about incentivizing them to be a part of their care, even if you charge, let's take the example Dr. Ginn gave about the woman who had a $920 income and she would pay $44 into her premium for her Medicaid policy. At that point, after she pays her $44, she really has no other restraints on her use of the healthcare system at that point. So she has no real incentive to curb her behavior, whether it be take care of herself better medically, her child. When a problem comes up, she can seek emergency department, which is, as the physician said, the most expensive care that we can do. What would be your feelings or your thoughts or ideas about possibly trying to take the Medicaid dollars that we're already spending and say, take a portion of that, instead of having the stick approach of you have to pay your $44 and then it's carte blanche after that? What if we took, say, $50 of what would normally be spent on her care, or $100 a year, for that same person getting that care already, and saying, if you participate in this system, if you meet these healthcare goals that we can set for you, if you come in and talk to, the nurse practitioner in charge of this clinic, or the physician here at this health clinic once a month or once every 6 months, and achieve these goals, then we will incentivize you with this gift certificate or this certificate for some. In other words, pay them to spend less. What ideas might you have with that?
That is interesting. Trying to think about that. One thing I would say is this just pays their monthly premium, right? So it gives them private health insurance, but they would still pay co-pays when they went to the doctor.
There's no co-pays for Medicaid, right?
But they would have private health insurance in this way. That's in the current system. Under this system, they would.
I'm talking about Medicaid as it stands right now. There's no co-pays.
Right.
So part of the reason we talk about a block grant is that we say, if we could do whatever we wanted with Medicaid, if we could institute co-pays, if we could raise the penalty for inappropriate utilization of the ER, which is about $8 in most states. Some of the states that expanded Medicaid tried to get it to bumped up to $10, and the federal government said, no, that's too much. So if we could change things like that, if we could institute co-pays, I think what you're talking about is not incompatible with what we're talking about, and perhaps it's sort of an all of the above approach. It's not an either or. I think population health management, what you were talking about, Camille, you would want to have those kinds of incentives built into those programs, no?
Well, and I want Representative Coleman to have a shot at this too. But two answers real quickly. First of all, research shows, and it has for 40 years, that if a person pays some amount for a service, that they are 80% more likely to comply with whatever they're asked to do. If they get it for nothing, it's worth nothing, and they don't comply. So that's answer number one. Number two is, I love your idea. But I think that we don't take an idea that's a great idea for Tyler where you are, where you want to do it, and we do that across the whole state. I think we need to regionalize, and I've worked with communities for the last 20 years. Communities are smart. They will tell you what's wrong with the system, and they'll tell you how to fix it, and they'll tell you who in the community can do it and who can't. We need to empower these local communities. You need to be a leader in Tyler to say, this is what I want to do. Here's how I want to do it. And then the bureaucrats aren't coming up with something they know nothing about and setting rules and regulations they know nothing about. You came up with the idea. You work with the people in the community, and then with the Public Policy Foundation, with your local representatives, your senators, et cetera, and you go about knocking down whatever the barriers are in the current system to keep that system from working. The best ideas never get off the ground, and they come from the communities because something else says, oh no, you can't do that.
Representative Coleman, I want to give you the chance with the final word here because we're out of time, but I wanted to give you the last word.
Well, thank you. I believe that people want dignity, and people don't have a problem paying if they can meet whatever the requirement is. And so that's something that's important. We have to do something different because as a consumer of healthcare, I know that I don't know enough to actually take care of myself and didn't ask enough questions. And I think that understanding one's illness or how to stay well is extremely important, and we're all going to have to be able to do that. So the idea that somebody understands not only what being sick is, but what being well is a big part of that $44 payment, because we need to be taught that, either through our interaction with our provider or through the health class. It's a very difficult thing. We're turning an aircraft carrier, as they say. The one thing that gets you closer to understanding a common price is having common plans. And that's the important part of bronze, silver, and gold, because you know that you're buying the same thing from everybody. You know there's a price that everybody's charging, and you know that, and this is what we have to get people, that they've negotiated a price with the providers on the reimbursement. Then that's where the difference lies. Right. So I think that these are things we're going to learn through these changes over the next couple of years, and hopefully be able to fix them.
And it's a complicated discussion, and we always run out of time when we're discussing these things because there's a lot to say. So thank you all for coming. Please join me in thanking our panelists this afternoon.